Good evening. Welcome to tonight's webinar on the ethics of heart transplantation. My name is Lydia Dugdale, and I'm the director of the Center for Clinical Medical Ethics in the Department of Medicine at Columbia University. I am delighted to be co-hosting tonight's event with Dr. Bob Klitzman and colleagues from Columbia University's Masters of Bioethics program. We invite you to put your name in the chat and to tell us where you're calling in from. And also later on, if you add questions to the chat portion, we will get those to our speakers during our Q&A time tonight. We organized this webinar in part because tonight's speakers, along with Dr. Bob Klitzman, myself, and members of Columbia Hospital's Ethics Committee have spent a lot of time over the last year discussing a relatively novel approach to obtaining hearts for transplantation. This process is known by the acronym DCD-NRP, which we'll go into in detail. It stands for donation after cardiac or circulatory death with normothermic regional perfusion. So just wait for it. But it's an approach that raises complex ethical issues. And since this topic among us has engendered so much conversation, we all felt it would be helpful to discuss with a wider audience. And so we are glad that all of you have chosen to join us tonight, and we really look forward to the question and answer period. So our plan for tonight is about an hour of presentation from the members of our panel, followed by about 30 minutes of question and answer time. So without further ado, I will introduce our panelists. All of us hail from Columbia University Vagelos College of Physicians and Surgeons. And then we will start tonight with Dr. Jane Farr. She's going to set up the discussion by describing the issue at stake, this DCD-NRP. Dr. Farr is the Irene and Sidney B. Silverman Associate Professor of Cardiology, and she is the Medical Director of the Adult Heart Transplant Program at Columbia. She will be followed by Dr. Kenneth Prager, Professor of Medicine and Director of Clinical Ethics at Columbia York-Presbyterian Hospital, and also Director of the hospital's Ethics Committee. Then comes Dr. Jonathan Hastie, who will describe the perspectives of doctors and donors when it comes to this issue in heart transplantation. Dr. Hastie is an Assistant Professor of Anesthesiology. And finally, Dr. Katherine Fischkoff will moderate tonight's discussion. She's an assistant professor of surgery and critical care and a member of the hospital ethics committee and an ethics consultant at Columbia York-Presbyterian Hospital. So we are delighted that you're here. We look forward to an engaging night together. Thank you so much for joining us, and I will turn it over to Dr. Farr.
Hi, thank you for the introduction. Would you bring my slides up? That's okay? Okay. So I'm going to speak about 20 minutes about donation after circulatory death heart transplantation, give you some background, and go through some of the concepts that were just introduced. Next slide, please. So the problem statement, that is, there are no formally defined clinical pathways to donation after circulatory death heart transplantation in the United States. Hearts from DCD donors are, by and large, not being allocated, despite these donors being younger with fewer comorbidities. And there are very few centers that have access to or have developed research protocols for procurement of DCD hearts using a variety of different methods. Next slide. So I'm going to talk about DCD transplant as opposed to DBD, or donation after brain death heart transplantation. I'm going to talk about how DCD heart transplant sort of came back around. It was the original heart transplant, back around to Australia and then to Europe and the UK and now to the United States. I'm going to talk about various retrieval algorithms for DCD, the potential impact of DCD, some of the definitions around DCD Maastricht 3 criteria, the dead donor rule, withdrawal of life support, and some of the data. And along the way, I'm going to raise some of the important ethical issues that will be picked up on by the rest of my colleagues during the rest of the presentation time. Next slide. So the history of DCD, the donation after circulatory death, the very first heart transplant done by Christian Barnard in Grooteschur Hospital in South Africa in 1967 was a DCD death. Christian Barnard actually trained with Norm Shumway in Stanford, and although we were more poised than any other part of the world to do the first heart transplant. We didn't have a formal definition of death in the United States. It was just circulatory. It was not brain death. And so in South Africa, there was an opportunity to perform transplant, and he did so, but really because it was a DCD death. There was co-location of the donor and the recipient to minimize warm ischemic time. And truly it was circulatory arrest and then organ procurement, and then quickly into the next operating room for implantation. Next slide, please. Coming into 1981, the Universal Determination of Death Act. And this is really, in the United States, the legal definition of death by statutory or case law recognized by all 50 states. These are the important components, and we'll get back to this. An individual is dead if he or she or they have sustained either irreversible cessation of circulatory and respiratory functions, or 2, irreversible cessation of all functions of the entire brain, including the brainstem. This patient is dead. The dead donor rule is an ethical norm stating that a donor must be declared dead in one of the above 2 ways before organs may be procured. The dead donor rule perhaps is outdated. One question that will be raised here today is neurologic criteria for brain death may be met, and yet there still may be brainstem function, particularly hypothalamic or endocrine mechanisms are still at work. One thing when it comes specific to transplant is whatever end-of-life pathway best respects donor or family wishes to relieve suffering and provide meaning and legacy to donate, in our minds in the transplant space is consistent with acceptable medical practices. If it is consistent, then it may be appropriate. And one thing that this raises is that the current acceptable medical standard allows that permanent may be considered instead of irreversible. So I'll leave it at that for the moment. Next slide, and we'll pick up that later. So to go through, how is donation after brain death and donation after circulatory death, how are they different? So let's go to standard DBD. We've been doing this for over 50 years here at Columbia. The first thing is that the prerequisite is that there needs to be a declaration of death, that the patient is considered brain death before there is organ procurement, of course. There's consent that occurs after the death has been adjudicated. Then there's organ evaluation and donor management. That can include antibiotics and drips and various maneuvers, and then there is organ procurement. This is in contrast to donation after circulatory death, because in this case, these patients are neurologically devastated and yet not dead. So there's consent for organ donation before there is a proclamation of death. There is then an algorithm for withdrawal of life-sustaining therapy, extubation. There is then a declaration of death, followed by organ resuscitation. We'll leave it at that for a moment because that's the DCD-NRB we're going to talk about. We'll just say followed by organ procurement by a variety of means. Next slide, please. The Maastricht Conference in Belgium in 1995 was really the first international conference on DCD that really defined different types of categories. When we're talking about any kind of DCD in the setting here today, we're talking about Maastricht 3, which is considered controlled circumstances, awaiting cardiac or circulatory death, which means withdrawal of life support is happening either in an ICU setting or in an operating room setting. There's a variety of different categories, and there's a lot of sort of more contemporary things going on, particularly in Europe, where there's Maastricht 4 and 5 categories, which even brings up concepts of euthanasia or uncontrolled, or even the category before that, uncontrolled procurement in the field. These are not categories we're going to discuss here today. Next slide. To look at this algorithm for donation after circulatory death, let's go through this again. One is there's withdrawal of life-sustaining treatment. The algorithm really is let's say we're in an operating room setting. There's a decline in blood pressure, and there's certain criteria under which blood pressure are we starting to see the patient truly die, followed by asystole. And then there's a no-touch or hands-off period. And in the state of New York, that's 5 minutes. And that's to make our best judgment that there's not going to be auto-resuscitation. What happens after that is organ retrieval. Next slide, please. To put this now in contrasting different forms of retrieval, the first part of the algorithm is happening whilst, followed by circulatory arrest, circulatory death, there's proclamation of death, and then there's procurement. There's two ways currently to do this, and there's variations on this. The first thing is by what's called ex situ normothermic preservation, which is that you take the heart out and you put it on a machine and it starts to pump. There's only one iteration of that machine right now, and that's the TransMedics machine. And then you bring that heart in a box or on a machine to the transplant center. The other way to do this is where the donor is in the same place as the recipient, in the same hospital. And so the first portion of everything is standard. And then there's something called donation after circulatory death with NRP, or normothermic regional perfusion using ECMO, which means that there's a declaration of death, there's an opening of the chest cavity. And actually, we'll go to the next slide to show this. This is heart transplantation using NRP. What this means is that there's an initial sternotomy, there's identification of head vessels, the left subclavian, the left common carotid, and the right subclavian, or the brachiocephalic. There's ligation of these vessels to be absolutely sure that there's no cerebral sensation or awareness, because these patients are neurologically devastated, but not brain dead. After there's ligation, then the patient is basically put on cardiopulmonary bypass machine, or VA, or veno-arterial ECMO circulation. That can be done, that is typically in this scenario done centrally. So there's cannulation of the aorta, and then the venous side, the SVC or the PA. And then what happens is the reperfusion of the body, inclusive of the heart, causes resuscitation of the donor heart. The heart starts to beat again. When the heart is beating again, that heart may then be further evaluated using echocardiography down the esophagus, or transesophageal echo, or invasive hemodynamics using a right heart cath, or none of those things, or you can just observe it. After there is a period of observing the heart, and then meanwhile there are other organs that can be procured, then there is a decision made to then remove the ECMO, allow the heart to beat on its own, and then proceed to procurement. So you can see how problematic and controversial all this can be. Next slide, please. Just to go back a step, and we'll get back to this in a moment, this is actually the TransMedics organ care system, and this has been used extensively in Australia and the UK, and this is in clinical trial here in the United States. This is the less controversial opportunity for DCD transplantation. Next slide. Just to put some, the UK and Australia, they're ahead of us. This is Australian data back since 2014. They've had a variety of different DCD protocols that are a combination, that are either DCD with NRP or DCD using the organ care system, or even a combination of DCD with NRP, and then you take the heart, put it on a machine, and you bring it to another center. I can tell you that the 1-year survival from the Australian cohort is excellent, and in many cases better than donation after brain death. Next slide, please. And you can see this in a Kaplan-Meier. Next slide, please. And then in the UK data, there's first to 50, so 50 heart transplants and a variety of DCD methods have been performed, and recently their 1 year and actually 5 years. So in some cases, 5 year survival have been reported, and they're outstanding. Next slide, please. I'll just mention the Liege protocol, which is somewhat controversial, and that is that there's pre-mortem instrumentation of the donor, and you can see there's femoral cannulation of the V and the A, or the arterial and venous cannulas, and this raises the question of donor management. Just to go back, donation after brain death, there's a lot that you can do in terms of donor management. You can give drugs, you can give antibiotics, you can give volume, you can give a blood transfusion. For DCD in this country, you cannot manage the donor. And so it's not optimal from the point of view of a transplant center where you need a little bit of donor management, but this is really an invasive procedures on a donor. And we'll just leave it out there because it's happening elsewhere. And this is part of this conversation. Next slide, please. Looking at what's the potential for DCD heart transplantation in this country, a couple of studies were done. One was done at Duke, and one was one that we did in the state of New York. If you look at, next slide, please. if you look, actually, I'll go back to, actually, we can stay here, but the Duke data really estimated that there might be 5,000 additional heart donors in this country were we to have DCD readily available to all programs. This is a slide, it's a couple of years outdated now, but we really looked at trends in transplantation in Region 9, which is the state of New York and then Vermont. I'll just turn your attention to just a couple of curves. The first is the top blue curve, which is all the donors there were during this time period of 7 years. And you can see it goes up and down, but it settled around 450. If you go down to the next curve, which is a sort of a mustard color, you can see that the donation after brain deaths donors started to decline. And then you could see all the way down the blue line, second to last, that DCD donors with anoxic brain injury started to raise. Really what we're seeing here is that by 2017, 64% of DCD donors had anoxic brain injury as a primary neurologic insult. Next slide. What this means are two. This is because of the opioid epidemic. Again, these patients are neurologically devastated, but many are not brain dead. Their organ procurement organizations, the entities that are charged with bringing organs to transplantation or the operational management of organ donation, their mandate is to transplant as many organs as possible. And when you have a neurologically devastated donor, there's big delays for them to progress to brain death, and anything can happen in the interim. There can be decompensation, infections, such that the donor is no longer viable. And so trying to facilitate organ donation and do it quickly is part of that means that you're approaching families and saying there's another way to do this, which is withdrawal of life support. This is beneficial for liver donation and kidney donation, non-controversial. There's not a problem with lung procurement in this fashion because there's an FDA-approved TransMedics machine. But heart is losing the battle here because every time you bring someone to DCD, you oftentimes, most of the times, lose the heart. And so if there's an active push towards DCD away from DBD, and this is happening, and also, again, the donor pool is not so much motor vehicle accidents, it's opioid overdose with devastation, but not brain trauma, that we're actively losing donors. We did a quick analysis, and I'll just go quickly here, and just to, again, estimate if we could identify what would be the perfect heart donor, a certain age, a certain ejection fraction, we could find that there would be a vast majority, upwards of many thousands of extra heart transplants would be possible in this country. Next slide, please. We did actually drill down, and we were given permission by the state to actually read some of the charts of donors whose families wanted to go to DCD. And even though many of these patients did meet criteria for donation after brain death, many of them, the donors themselves, however young, were of age and had already consented to donation. Family preference dictated the terms that the families wanted to be present. They wanted to say goodbye and participate or observe withdrawal of life support. And so there's a whole movement towards DCD donors, even when criteria for donation after brain death are met. Next slide, please. And then just a last couple of slides just to look at the state of DCD transplant in the United States. The top slide, all transplanted. DCD donors, in 2019, there were 5,262, which is in addition to the brain death donors, which is upwards around 30,000 potentials. And so again, you can see what the opportunity is. Next slide. And in New York State, you can see that in 2019, 2020 obviously was a difficult year because of COVID. There were 117 DCD donors, and to add 117 potential hearts to this region would be a game changer. Next slide. And we can just skip through this. It says something similar. And so going back to the TransMedics DCD trial, next slide. This, I think we can play, just so you get a sense of what this mode of operation is. It may not play, but it's a beating heart on a machine. And this is in clinical trial, and this may take a couple of years to sort of put in play, but this is expensive, and not all programs can do this. Next slide. And this is just this is the FDA panel in terms of trying to bring TransMedics to approval. Next slide. So let's go back to a DCD with NRP. This is being done in a number of centers in the country, most notably NYU has taken the lead with this. Vanderbilt and others are following suit. Next slide. And so really, let's just walk through a couple of the steps. Consent is obtained from the donor family by the organ procurement organization to proceed with DCD. That patient is then transferred to the center. I just used the example of NYU here, although other centers are doing this. This clinical trial is actually NYU, so that's what the number is. Obviously, the consent is obtained by the clinical team, who will not perform withdrawal of life support. In this protocol, the donor is typically brought to the operating room setting. Circulatory rest is determined by absence of pulse and organized cardiac rhythm. Death is declared by an MD not associated with transplant. And then importantly, and we can talk about the details of progressing to circulatory rest, importantly for anesthesiologists, Dr. Hastie will address this later, is that the anesthesiologist is asked to re-intubate this patient, and then the surgeons will do the sternotomy. Next slide, please. Once you get the patient back on cardiopulmonary bypass or on cardiopulmonary bypass, the heart will start to beat. And at 30-minute intervals, the donor will be separated from cardiopulmonary bypass to look for standalone functionality. And then the ECMO will be withdrawn. Well, it doesn't have to. And then actually what you're doing is a standard DBD procurement. All that really means is that the procurement part is just absolutely standard. Next slide. And in their particular clinical trial, they were looking at some primary outcomes of rate of successful NRP DCD, inclusion criteria and exclusion criteria. And they're actually going to publish on this data, I think, pretty soon. Next slide. Next slide. Okay. And this team at NYU, to their credit, they partnered with ethicists, including Arthur Kaplan, to really try to get ahead of this question, or at least in step with the questions of what are the ethical and logistical concerns around NRP with DCD. Next slide. And it really came down to some basic things. A couple we've already addressed. Basic things. Donor conversation with family must take place only after a decision to withdraw support. Families need to make that decision independently. The primary medical team must not initiate this conversation. That is under the guise of the organ procurement organizations. Conversation must emphasize the separation of the clinical care team from the procurement team. This is very, very important for anesthesiologists. Circulatory death of irreversible cessation of circulation or respiratory function in their minds, and this is what is potentially proposed, should likely be changed to permanent cessation. And more contemporary concepts of brain death, such as permanent coma, were not specifically addressed in this particular protocol or paper. Next slide. And so just to end up with a couple of slides, just to review the strategies that we discussed. The first thing is no premortem instrumentation. In this country, for either protocol that's on the table, there's no premortem instrumentation of the donor. Direct procurement is this Transmedics machine. I did put up cold storage where you actually can procure and put under ice, but really nobody's doing that. But there is on the horizon something called the Sherpa Pack, and there may be a DCD trial, or ex situ regional perfusion, which is the Transmedics machine. The other option is NRP with, as we'll say, reanimation of the heart on VA ECMO. And then, okay, so next slide. And then I'll turn it to Dr. Prager to move into the ethical issues. Thank you for your time.
Thank you, Dr. Farr. What I'd like to do in the following 10 minutes is to raise and go into a little more detail some of the ethical issues that have been raised with this protocol of DCD-NRP. Can I have the slide, please? Okay, next slide. So I'm going to repeat what Dr. Farr said. The dead donor rule, which is critical to all of this, that retrieval of vital organs should not cause the death of the patient. The patient has to be dead before retrieval of, in this case, the heart. The dead donor rule is critically important because it promotes societal trust in organ procurement by promoting trust in organ transplantation. The public is assured that medicine will focus on a patient's best interests and not on the possible benefit to others, even if the need is great. Clearly, that people will not fear if they're coming into a hospital and they're critically ill that they will have their organs removed even before they are dead. Next slide, please. So there are two definitions of death in the United States today. The Uniform Declaration of Death Act talked about circulatory definition, which initially said it was the irreversible cessation of circulatory and respiratory functions. Now, actually, this was modified already with the advent of DCD from irreversible cessation to permanent cessation, which is really the traditional definition of death. Let me just give you a scenario. In a hospital, in a patient who is DNR, if you are called as a physician to the bedside of the patient and the nurse says the patient to stop breathing, and that patient has no pulse and no respiration, we don't necessarily wait 5 minutes before we proclaim the patient dead. Since there is no intent to resuscitate the patient, that cessation is permanent because the intention is not to resuscitate the patient. And therefore, the definition has been modified from irreversible because, in fact, with DCD patients, it is possible to reverse the circulatory arrest with resuscitation. But since we do not intend to do so, it is called permanent because that is our intention. The brain death definition, of course, is the irreversible cessation of all functions of the entire brain, including the brainstem, and that has raised some questions whether this is truly all the functions. As Dr. Farr mentioned, hypothalamic function can persist. Next slide, please. The Institute of Medicine made a statement in DCD in 2000 that the reason that the circulatory definition of death is met in the DCD protocol is that after the hands-off period, which is about 5 minutes in New York and in most places, there is permanent cessation of circulation, as I mentioned before, because there is no intention to resuscitate the patient. And the Institute of Medicine stated, death occurs when cardiopulmonary function will not resume spontaneously and I italicized this, will not be started artificially. They recognized that after 5 minutes, you could resuscitate the patient. But the patient, in that case, if the intention is to resuscitate the patient, then the patient is really not dead after 5 minutes, certainly if resuscitation attempts are made. The DCD NRP protocol violates this stipulation because it resuscitates the patient after the hands-off period by means of ECMO. Next slide. In an article by Bernat et al., The Circulatory Death Determination in Uncontrolled Organ Donors, a panel viewpoint, this was back in 2014, they stated very clearly, we advise against the use of post-mortem organ support technologies that reestablish circulation of warm oxygenated blood because of their risk of retroactively invalidating the required conditions on which death was declared. Those conditions were that there would be cessation of circulation and respiration, and there would be no attempt at resuscitation. Once that is violated, then the declaration of death basically is invalid because circulation is restored via resuscitation. Next slide. Now, the article that Dr. Farr quoted by Dr. Kaplan and his colleagues, which appeared in 2020, they had to get around the problem of the lack of permanent cessation of circulatory function because clearly circulatory function in the DCD-NRP protocol is restored. It is not permanent. And so they stated as follows to get around this. Perfusing organs after declaration of death does not undermine the permanence requirement. Why? Declaring death by circulatory criteria requires that circulation will not restart on its own, and the medical team must not intend to restart circulation, and this is what they added, for purposes of the patient's medical benefit. That was not present before. They had to add this because if they left it without that, then the medical team did intend to restart circulation, and therefore the circulatory criterion for death would not be fulfilled. And so they added, somewhat arbitrarily, some would say, if it's added, if circulation is restarted, but not for the purpose of the patient's medical benefit, that does not violate the circulatory definition of death. And some would consider this rather arbitrary to justify ethically the DCD-NRB protocol. Next slide. The ligation of cerebral vessels is the other basic ethical problem. And I'm quoting again from that article, and they state that once the patient is declared dead in accordance with accepted medical standards and natural neuronal hypoxemia and ischemia progresses to complete irreversible loss of brain function unimpeded, it's then impossible to restore circulation in a way that restores life. Now, the reason that neuronal hypoxemia and ischemia progress to complete loss of brain function is because the physicians have ligated the vessels perfusing the brain. It is the physicians who have ensured complete loss of brain function by their actions. It was not natural. Death has not taken its natural course. In order to prevent brain reperfusion when circulation is restored, brain death has been caused by physicians. Next slide. There are some other ethical issues that some people have raised. Number one is that since there is an ex situ alternative to in situ NRP, including hypothermic and normothermic organ reperfusion, this can be achieved by machines outside the body. Why tamper with the definition of death? Why raise these profound ethical issues when it is clearly ethical to allow the patient to die, not to reinstitute circulation, remove the heart when the patient is truly dead, and then reanimate the heart, but not the patient in an ex situ machine? Number two, DCD has increased significantly, as Dr. Farr mentioned, due to the U.S. drug overdose epidemic. This protocol may disproportionately affect an underserved or stigmatized population afflicted with the nation's substance abuse epidemic. Would this violate the requirements of justice, calling for an equitable distribution of benefits and burdens within society? And finally, what about the consent process? How valid would informed consent be given the complexity of this procedure and the subtleties of the definition of death? Do the family really understand what is happening? Next slide. In summary, the current DCD-NRP protocol appears to violate the dead donor rule by resuscitating the patient donor, thereby violating the circulatory definition of death, which requires the permanent cessation of circulation. It does not depend on whether circulation is restored for the patient's benefit or not. Furthermore, the vessels to the brain are ligated prior to resuscitating the patient, lest circulation to the brain prevent brain death. This action of the physicians ensures brain death in a still living patient. Next slide. It is one thing to remove the living heart in a brain dead patient. It is another to cause brain death. In a still living brain in a patient whose circulation has temporarily ceased. Last slide. And so there might be possible solutions to the problem. Obviously, we want to increase the number of hearts as much as possible. Are there ways around this? Well, possibly. We could revise once again the circulatory definition of death. However, if this is to be revised, it should be done by societal consensus, not by a single ethics committee of one hospital making an arbitrary redefinition of what circulatory death is. Or society may decide that the dead donor rule is outdated and may be violated for purposes of organ donation. Thank you. That is my presentation.
I'm Jonathan Hastie. I'm the medical director of the CTICU at Columbia, and I appreciate the opportunity to speak on this panel. If we could put my slides up, please, that'd be great. So I have really very much enjoyed listening to the first two panelists and would like to take a little bit of a different perspective here in my clinical work as an anesthesiologist and an intensive care specialist, as well as the relationship we have with patients and the meaning that it brings to bear on the situation. Next slide, please. So in the next 10 minutes or so, I'd like to just touch on a few different elements that pertain to this topic. The first would be the patient-physician relationship to the anesthesiologist and the intensive care specialist in the setting in general, but also in this particular DCD setting. Secondly, I would like to discuss briefly what death looks like in the ICU and the meaning that has for physicians and patients. And then thirdly, a couple more practical ethical considerations that are, I think, related and grounded in what Dr. Prager discussed, but have a little bit more of a physician and physician orientation. Next slide, please. So as we all know that the patient-physician relationship is fundamental in the practice of medicine. It's the relationship that allows us to deliberate together regarding decisions on health and to apply advances in scientific knowledge to specific patients, to think about treatment decisions and to place those within the context of a patient's values. This relationship forms the basis of shared decision-making in which both the physician and the patient are able to take in information, to reflect on that information and to form opinions. And this relationship is underlined by trust, that there's an unspoken understanding the physician has a fiduciary responsibility to the patient to put their needs first. And it's not just an unspoken understanding, it's also written in the Hippocratic Oath, to do no harm. So as we reflect on this patient-physician relationship, we think about applying it in ever more, what that relationship looks like in ever more complex situations. And I think we would all agree this is one. In my work with Dr. Prager, Dr. Farr, and others in the ICU setting, I noticed some of the most challenging, but also the most rewarding experiences have to do not with the science of medicine, but the art of medicine. So as we think about this patient-physician relationship as applied to ICU and anesthesiologists, this third bullet point, distinctives of practice, it's, I think, the same as any clinician or hospitalist, and yet there's some distinctives or degrees that are noteworthy. Number one would be the time with the patient. The anesthesiologist's interview with the patient is notoriously short. It may be as short as 5 or 10 minutes before a major operation. And the setting is one that is a stressful environment and a high stakes environment for the patient and their family. As such, building a relationship takes intentionality on the part of the clinician. For the intensive care specialist, the patient may be sedated and unaware for the entire duration of the care. And so this relationship is moderated and mediated through the patient's family, during which time deliberations often take place with a retrospective point of view to think back what the patient valued and apply that looking forward. Next slide, please. In terms of the anesthesiologist clinical encounter, we can divide this into the preoperative, the operating room, and the postoperative time periods. In the preoperative time period, as I said, the pre-op interview is a time, number one, of course, to exchange information, but secondly, and far more importantly, is to build a relationship of trust between the anesthesiologist and the patient. In a brief time period, this has to be done with intentionality, and there's various both verbal and nonverbal ways that we do this. In the operating room, I think the part of the reason that I'm here discussing this is because the skills that we use as cardiac anesthesiologists overlap with the skills that are needed for a successful DCD regional perfusion program in terms of intubation, resuscitation, use of echocardiography, and the use of potent vasoactive medications. Next slide, please. We'll actually skip to the next as well. So in these three different phases of the anesthesiologist encounter, we can think about the meaning of the patient-physician relationship in terms of preoperatively establishing relationship and understanding the patient's values and hopes. In the operating room is a time of, it's a physiology lab on the one hand, but on the other hand, it's a time of great vulnerability for the patient, where the medications we administer take away the drive to breathe, take away the ability to move. And we provide medications that take away the patient's ability to sense. Next slide, please. In the interest of time, I'm going to keep these comments brief, but in terms of the ICU, the clinician's relationship to the patient, this is a complex environment in which assessments are made of the patient's directions, decisions are made about the direction of the patient's care, coordination between a multi-specialty team, as well as rich interactions with the patient's family. What I will say is that I tell my trainees that in the ICU, 50% of what we do is medicine and the other 50% is politics. And I mean this politics in a good way, of using a deliberation and shared decision-making to decide, to make decisions that reflect our collective values. Next slide, please. So we've talked about the patient-physician relationship that underlies all of our practice in medicine and some of the distinctives for the anesthesiologist and the intensive care specialist. Secondly, I'd like to talk about what death looks like in the ICU. Next slide. When we withdraw life-sustaining therapy in the ICU, in what Dr. Farr was describing in a controlled environment, we attend to many things at once. There's the medical care that's provided, whether it's mechanical ventilation or the withdrawal of vasoactive medications, the administration of sedatives, of pain control, as well as dosing of other medications, for example, antipsychotics to reduce airway secretions. We attend to the environment of care as well. From a very practical standpoint in the ICU, when we withdraw life-sustaining therapy, we dim the lights, we ensure a quiet environment, we put up privacy screens, and we make sure the patient's family has chairs to sit in, water to drink, and there's a blanket that covers the patient with a special emblem provided by the nursing team. When the time comes to declare death in the ICU, what strikes me as a powerful idea is the relative ambiguity that if we have a patient on the floor who dies, we examine, we listen for a pulse, we auscultate, we look for reflexes, and if those are not there, then the patient is declared dead. In the ICU with advanced monitoring, specifically an arterial line and continuous ECG monitoring, a patient that may look dead in the floor setting in a non-monitored setting may look to be severely hypotensive in the ICU setting. And so there are shades of gray in terms of the information we get about the patient and our ability to declare death. As such, if we withdraw vasoactive medications in a patient still on the ventilator, I wait until asystole occurs and persists until I withdraw the ventilator. When the moment comes to declare death, the role of the physician takes on a ceremonial, almost priestly role, where I may know the patient is dead from the advanced physiologic monitors, and yet going in and laying hands and examining the patient is part of a role that the family sees and observes. I would like to emphasize the wholeness of this process, that it's not simply the act of the physiological determination, but attending to the family, the patient, their values, the environment of care, and respecting that death is a process, that it begins, there's the declaration, but it also continues as the family sits with the patient, cries, and shares memories. Next slide, please. In what we have proposed in terms of DCD, normothermic regional perfusion, death would occur in the operating room setting. From a patient and family standpoint, this would be a very sterile environment. With limited ability for family to be there to interact. It wouldn't be as comfortable either. What Dr. Farr highlighted and then Dr. Prager emphasized as well would be the process of, after death is declared, of clamping, of ligating the head vessels. And then the reanimation of circulation with the intentional blockade of circulation to the head. Now, this reanimation, cannulation for ECMO, would be done by surgeons, by anesthesiologists that have advanced knowledge, and we can see how this would cut against the normal skills and the normal ethics and professional practice that we have. Next slide. And so, in contrast to death in the ICU with withdrawal of life-sustaining therapy, the idea of declaring death after cardiac arrest and normothermic regional perfusion, it is a great tension, a dividing line of sorts. Instead of death being a process, there's the moment of declaration, a few minutes of hands-off period, and then everything changes. The process of death is foreshortened and comes drastically to an end. In addition, for the people that are resuscitating the heart, we're resuscitating not for the donor, but resuscitating for the recipient. In a very tangible way, this is a disembodied experience. Instead of caring for a patient and their body and their family all at once, we are resuscitating an organ separate from the care from that patient. We haven't spoken specifically about who would be resuscitating, but I would have concerns if it was also the anesthesiologist that would be caring for the recipient. Are they using the best judgment in resuscitating that heart if they've already met the recipient and are advocating for them? And what if they fail in resuscitation? What burden does that imply for them? Next slide, please. So in closing, to touch on a couple ethical considerations, next slide. We've already mentioned the idea of autoresuscitation, that after the declaring of death, there may be the restoration of circulatory function. Now, this study didn't use the term autoresuscitation, but rather resumption of cardiac activity, which was really the reformation of QRS complexes and a pulse pressure of 5 millimeters of mercury, which is minimal. Of these patients, 14% developed some cardiac activity. Most of it occurred after being, quote, dead after just 1 or 2 minutes. The median duration of resumption of cardiac activity was only a matter of seconds, 3.9 seconds. However, that range was from 1 second up to 13 minutes that cardiac activity could recur even after the declaration of death. Next slide. As Dr. Prager highlighted, the definitions of death depend on consensus definitions here. And this consensus statement by SCCM, ATS, ISHLT, and others emphasize the fact that this is simply legal clarity to define what we are doing. And there's value to that, but legal clarity is not the same as philosophical or conceptual consensus. In addition, the consensus statement it says that institutions should respect the fact that there may be conflicting views on the matter in a pluralistic society. Next slide, please. And so with Kant in mind, I think about the categorical imperative we have as physicians to put our patients first and to care for them in the dying process in a way that demonstrates respect for personhood. And that's contrasted with the hypothetical imperative of the resuscitation process of the heart, not in the end of itself, but for another purpose, that is to transplant. Last slide. And so from the patient and the physician standpoint, from program design, I would emphasize the value to thinking through this carefully. As we said, that the withdrawal of life-sustaining therapy is performed by a team that is taking care of the patient and the patient only. After the declaration of death, the resuscitation would be done by a physician, by a person that is well-trained in these sorts of things, and yet is functioning here not as a physician, but simply as a physiologist to resuscitate that organ. And I would advocate strongly that that person would also be separate from the clinician, the anesthesiologist that would be involved in the transplantation, who is the physician and the advocate for that patient. In addition, there would be the same questions, I think, for the clinicians about the definitions of permanence and the very act of ligating the vessels and the implications for the physician's role there. With that, I will close and thank you for this opportunity to speak.
That was wonderful. This is exactly why I feel so fortunate to be able to work and have been trained by the three of you. Maybe I'll begin by just reminding the audience, please, to put any questions in the Q&A box. I will start off with a couple of questions and then I'll go to audience questions. But maybe Jane, Dr. Prager always says that the ethics flow from the facts. So maybe I'm just going to go back for 1 minute to the facts, just to sort of lay out a little bit more of the problem. Do you have any sense of how many patients are on the waiting list for a heart every year, how many get a heart, and how many die on the list waiting for a heart?
Yeah, so currently in the United States, at any given time, there might be something like 7,000 patients awaiting heart transplantation. It's a dynamic list. People are on it and off it. But as of last year, and that wasn't, actually it was a good year, around 3,600 patients, adults and peds, underwent heart transplantation. Waitlist mortality can vary greatly depending on acuity of medical illness. It's a really hard number to get at. I can tell you that what we say to patients is for every one person who gets a heart, 8 patients die waiting. So the demand far exceeds the supply.
So just so I can clarify, so there are a few thousand patients a year that we cannot serve just with a population of donation after brain death donors.
Yeah.
And even with a small supply of DCD with perhaps a transmedic, we're still short many, many thousands.
Yeah, and I just would take it one step further. There are, if you look at a heat map of end-stage heart failure across the United States, who makes the list is just an absolute fraction of where the need might be. Because of wait times and opportunities and specialized centers, there are many, many patients who are dying of heart failure without the opportunity for heart transplant, because you actually have to select only the best candidates or the most viable candidates because of organ scarcity. And we spend much of our lives and careers talking about allocation rather than just taking care of patients, and where allocation is a part of what you do, but it's not the front and center of everything.
Yeah. And so the results of donation after circulatory death with the NRP protocol, you had mentioned there are a number of hospitals in the country that are doing that. How do they compare to the donation after brain death?
I will make the guess that they are in range or equivalent. I don't have any data. There's, at least in the UK, the outcomes are equivalent. There'll be some publications in the United States, but there's good data internationally to support this as a viable option, at least from the point of view about a patient and recipient outcomes.
Yeah, certainly. I know I have the papers you're referencing out of Europe, and some early results from NYU show excellent results of DCD with NRP. Perhaps even numbers are obviously much smaller than our experience with brain death donors, but perhaps better even long-term outcomes. And then just one more point just to focus on the transmedic, the ex vivo, the heart in a box.
Yeah.
Can you just tell us what the barriers to implementing that is?
Well, number one, it's in clinical trial. So that's the first thing. If you're only one of the 8 or 10 centers that it's available in a clinical trial, and that trial is actually closed and it's in continuous access, there's very little access to that as a current modality. And that will have to go through FDA approval and all this other stuff. It's expensive, and it requires specialized expertise, as does the other protocol, for sure. But it's just not currently available.
Okay. And then just to hover a bit longer on sort of facts and procedure, Jonathan, can you tell me a little bit about the intraoperative, preoperative management or intraoperative management of brain death donors and circulatory death donors? Do you know, are brain death donors put under anesthesia when they're brought into the operating room?
So that's a great question. It's a difficult question to answer in the sense that there can be overlap between the medications we use to support physiologic function and medications that we use to anesthetize patients. For brain death donors, what's commonly done is that there may be physiologic hormonal replacement in terms of thyroid hormone, steroids, or the use of vasoactive support. And so those medications can be thought of as supporting the physiologic or the circulatory function without thinking about anesthesia. There's no need to use a volatile anesthetic or a sedative hypnotic. So the sevoflurane vapor or propofol, for example, would not be needed. However, the use of opiates would be something that could be considered in the sense that they have peripheral effects and effects of the spinal cord. And so if there are sympathetic responses that are mediated not in the brain but in the spinal cord, that the role of opiates could be used. And that's an example of one that has a lot of overlap between what we think of as an anesthetizing medication and one with other physiologic effects. You mentioned cardiac, but that would be deceased after cardiac death will be for non-cardiac transplant cases is performed in the operating room, but it's typically withdrawal life-saving therapy by the ICU team, and there wouldn't be a role for the anesthesiologist in that setting. It's only in this cardiac setting where we would talk about normothermic regional perfusion that we would introduce the idea of the cardiac anesthesiologist.
Because I suppose the very idea of providing pain medication to a patient during donation after brain death is a little bit confusing, because it suggests perhaps that we are attributing some sensation or something, or some at least measure of protection, maybe even just for ourselves in in that process. This is great. I'm getting a bunch of questions here in the chat box. So I'll just ask one more, give people a little bit more time to put in their questions, and then I'll turn to audience questions. Jonathan and maybe Ken, if you could both talk a little bit about what you think the difference is, sort of, you presented a beautiful picture of what it's like to withdraw care in the ICU, and the care and devotion that the patients and the families get from nursing. But in terms of the actual declaration of death, is there a difference, do you think, in the ICU? Do you wait 5 minutes in the ICU to declare death in the same way that you would in the operating room after circulatory death? And if you don't wait in the ICU after withdrawal, is there a reason not to?
That's a fascinating question, and I think that preparing for this panel has made me reflect in a different way on our practice up till now. And I think that what gives the most clarity about that specific question would be what Dr. Prager talked about, that if a patient is DNR, there's no waiting period, there's no intention to resuscitate that patient, and so death can be declared immediately. And I think that tracks well with our actual lived experience in the ICU, that if a patient is DNR, or if there's a code, CPR, that's not successful to resuscitate a patient, that death can be declared as soon as the criteria is met, which I'm not going to reiterate now unless there's interest in that. I think the one instance that would lead to a nice illustration, I think, of what we're talking about as it may come up in the ICU would be the settings where there is a withdrawal life-sustaining therapy, and we're simply waiting from afar, looking at central telemetry monitoring to look at the blood pressure and the heart rhythm. And quite a few times, in fact, most of the time, I see a systole develop. And we get up from the chair and think, okay, let me step in to declare death so that the family understands. And many times they know, they're looking at the monitor too. And so many times we get up and then there's a few more blips of the QRS complex. Sometimes it goes on for another minute or two. And so that pause the asystole duration may only be a matter of seconds, but it fools us enough to lead to some of that ambiguity here. So that would be a form of a hands-off period or a waiting period that happens naturally, because we want to be certain that asystole occurs so we don't go in and declare death and then see there's a few more beats. It leads to, it's not any moral ambiguity, but it's rather some confusion perhaps for the patient's family if we declare too soon.
Yeah, I would just add that in a situation when the patient is DNR, the exact moment of death is somewhat moot. It's somewhat irrelevant. Since there is no intention of resuscitating the patient, whether that patient is considered to have the irreversible cessation at 3:12 or 3:15 really makes no difference, because there is not the intention to resuscitate. And that's why there is moral ambiguity in this entire DCD NRP protocol, because there is resuscitation that occurs, or if you will, reanimation. And that's why the paper that I quoted stated, well, it's permanent. It's not permanent, but since the resuscitation is not done for the benefit of the patient, then we consider it the circulatory definition of death to have been fulfilled. And some people feel that that's a bit, that's rather arbitrary and tendentious.
So this question of intent and the exact moment of declaration of death is actually a great segue into one of the questions that we've gotten from the audience from Meryl. And Meryl asks, and this could be for anybody, I think, if the patient agrees to be a heart donor, are the best interests references transferred to the recipient patient? So I think that is kind of the idea or she's getting to the idea of intent. Jane, if you'd like to start.
Yeah. So, the one thing that's really important to underscore with families of donors, whether they're DBD or DCD, is that sometimes families can be devastated when there's failure to donate. That part of the interest in donation is to create legacy and meaning out of something that is so tragic, and so there's that. And then it is a loss to society. This is, there is a huge loss to society, and the numbers are staggering in terms of the unmet need. With regard to in terms of maleficence or benefits, it's obviously important to go through these important details of ligation of head vessels and depth. I mean, the definitions are extremely important, but the overall intent is to contribute and to do this in the most ethical way possible, and to address the fact that a DCD donor is neurologically devastated, and it's very difficult. It's very difficult. So let's just go to the opioid overdose donor. I don't know if we want to get into this very much, but it's really hard to make brain death determinations in a drug overdose, and it can be days and days. And if there is indeed enough evidence of neurologic devastation, then in aggregate, and if a family decides there's going to be withdrawal, you can wait for brain death. And actually, we didn't even get to the topic of if a DCD donor progresses to brain death, and then what we do, but maybe we won't go down that alley. I think I'll stop there, but I just wanted to raise the issue from the point of view of being a transplant physician. It's actually devastating for people to die on the wait list when there are organ donors that want to donate and are unable to, because we are trying to find the right appropriately ethical definitions for how to do this.
I agree with everything that Dr. Farr said, but I'm going to give a countervailing argument and say that if really the intent of the donor is so critically important and for the family to give meaning to the death of their loved one, which I can certainly understand, and it's true, and we can save lives this way, then why go through this whole rigmarole of DCD NRP? Why not just take the patient to the OR, give them anesthesia, and take their heart out? This would be probably more, it would result in better hearts, I think, than having to go through waiting for them to die, waiting for them for their heart to stop, I should say, recannulate them, ECMO, ligate the vessels. Just take them, give them general anesthesia. They're going to die anyway. They're neurologically devastated. Because the definition of death is critically important. And I might say that there are countries in Europe where this is done.
Yes.
Where actually they euthanize patients because euthanasia in certain circumstances is considered legal. And if a patient says they want to link their death with organ donation, they will and have taken patients to the OR, and their death is carried out as a result of removing their vital organs under general anesthesia. So my point is then that, it's critically important for these definitions to be adhered to. It's a question of life and death, and we shouldn't, I would like to say, fudge these things and make it grayer around the margins because of the consequences and the importance of when somebody is dead or when somebody is alive, when we might be killing somebody and when we might not be killing somebody.
I'm just going to go ask one small point, and then there's a lot of questions in the chat about the ligation of the cerebral vessels. But Ken, I just want to ask you one question. You had mentioned in your comments one of your concerns was about the ethical principle of fairness and justice, and the concern that the opioid epidemic disproportionately affects communities of color, marginalized and underserved communities, and perhaps that DCD with NRP would be taking advantage of those patients. I wonder if you see a difference. Those patients are already being approached as part of the donation after brain death protocol. Do you see that this is any different, or it's the same population?
No, I think that's a problem. I think it is problematic. Frankly, I raised that in my talk. I personally don't feel that is as compelling an ethical argument, frankly, but I do think people are concerned about that, and they do see a particular disparity in the sorts of people who may be donors versus recipients. Yes, it's true in brain death. Yes, these are patients also who may be from disadvantaged communities. Prior to this, I might add, most of the brain death patients were from trauma, from motor vehicle accidents and so on. And so the demography, shall we say, of who is a brain death donor has changed somewhat as societal issues have evolved.
Let's use this to get into the topic of brain death and the ligation of the vessels. Can you just give a brief overview of the genesis of how brain death became defined and how it's evolved?
Yeah, well, brain death, the notion of brain death was created in 1968 by an ad hoc committee of physicians at Harvard Medical School. I always like to say that these were my professors. I graduated from that institution in 1968, and I knew these people. And in a sense, they had the chutzpah to come up with a new definition of death. I mean, just think about it. Some people creating a new way that you can die. But clearly what motivated them was the new technology that could keep a heart beating with somebody on a ventilator after they had no cerebral function, except perhaps for the hypothalamus. And for years and years, this went on. The reason for the creation of the brain death definition, in my opinion, was to give ethical justification to organ transplantation, so that when we remove the beating heart of a patient, we're not killing him because the patient is dead by a different criterion, namely by brain death. Over time, though, this definition of the irreversible cessation of function of the entire brain, death of the entire brain, including the brainstem, has been proven to be incorrect, because the hypothalamus does, in fact, continue to operate in many of these patients, not all of them. And so it's really not technically exactly correct. In England and in India, they have adopted a different definition, and they call it not brain death, but they call it irreversible apneic unconsciousness. And the two criteria for saying that these patients are dead, not that they're brain dead, but that they are dead, is if they have irreversible coma, irreversible unconsciousness, and irreversible apnea. I think to prove these two criteria, the same criteria are used, namely the clinical criteria of looking at the cranial nerves and doing either an apnea test or a perfusion test that shows no blood perfusing the brain. But they avoid using the term brain death, total brain death, because it does not reflect biological reality. And I'll just read to you, if I may, why they feel that this is a legitimate definition of death. Because they feel that brainstem death is death because it, quote, entails the irreversible loss of those essential characteristics which are necessary to the existence of a living human person, unquote. It's not the biological death of the entire organism, because obviously there are parts of the organism that continue to work. But and I think, frankly, this is a more accurate definition of death. However, it still uses the same criteria that we use to diagnose brain death in America. It's just called something different, and I think what it's called is more accurate.
If we were to use that definition, how would you square with DCD with NRP? If we change the definition of brain death, what would be in my mind, the positive implications for organ donation in the United States?
Well, I think in that circumstance, Jane, unless you carried out a formal brain death examination of the patient, namely testing the cranial nerves and doing an apnea test, you could not be sure, since these patients were neurologically devastated, but they did not fulfill the criteria of brain death, then I don't know that they would fulfill that criteria if you were to do a formal examination and an apnea test, which is clearly not possible without having, it takes time, et cetera, et cetera. So if there still is some perfusion of the brain, that person may not, in fact, fulfill the criteria of permanent apnea, probably permanent unconsciousness, but whether that patient would still make some efforts at breathing and show that the brainstem still had some function, it might still be present, and therefore the patient is not dead, does not fulfill that criterion.
So just to clarify the ligation of the blood vessels, did you want to address that?
Yeah, please.
So it is my understanding, and please someone correct me if it's not quite right, and that is for the DCD with NRP, there has been a declaration of death by circulatory criteria. And so the patient is then considered dead. And the ligation of the head vessels, as I understand it, is really to ensure that there isn't any residual sensation that could be occurring.
Yeah, but the problem is, the problem is that declaration of death is contested by those who feel that since the patient is being is going to be reanimated, if you will, or resuscitated, that the patient is not really dead. There is an intention to resuscitate that person, and so cessation of circulation is not permanent.
Yeah, no, that's just two different things. I'm just saying that I think the purpose is, as part of the algorithm of the ligation of the head vessels, is that you don't want any neurologic sensation
Correct.
to occur, and that it would be considered legal to do so because there's already been a declaration of death. And in that case, then you can at least by legal algorithms, what's the word, instrument or manage the donor.
All of that is contingent upon your acceptance, though, of the declaration of circulatory death. If you don't accept it, you're ligating the brain vessels in a living person.
So what's wrong with individual centers accepting a definition?
Well, I think that the magnitude of the declaration of the definition of death is such that this should be done on more than just, Columbia Presbyterian feels that this fulfills the definition of death. When we did DCD, the Institute of Medicine declared this, and there was general acceptance across the country that these fulfilled the criterion of death. This has not happened to my knowledge with the DCD NRP. And one institution saying, the ethics committee or whatever at NYU saying, well, it does fulfill the definition of death because you're not resuscitating the patient for the benefit of the patient. That's their interpretation, but clearly it is open to disagreement by many areas. I think something of the magnitude of the importance of a definition of death should have societal consensus.
I guess the only issue, though, is from an operational or practical point of view, societal consensus on changing the definition of brain death could take years. And in the interim, there's this ever widening gap in being able to save lives and watching people die on the wait list when there are viable organs, upwards of 5,000 organs a year, that could absolutely get rid of all types of allocation and scarcity and death on the wait list. And so while the best case scenario is to have total societal consensus on this, the lag time is significant, especially when there is so much precedent in other countries.
Well, the number of countries that do this is really rather small, Jane, right? Australia, England. I mean, there are hundreds of countries in the world. I don't see this carried out there.
That's true, except that it has made such a meaningful impact. There's so much organ scarcity, let's say in the UK, that their ability to transplant their wait lists is been outstanding. I mean, it has been one of the most impactful things in thoracic transplant that could have been imagined. And so you take the lesson.
I would also say that if it is that important to close the gap, why not put all of our resources and time into the ex vivo heart transplant process? Let's put a lot of time and money into that and research. That will avoid the ethical issues that are raised.
I'm going to jump in just to direct some of the audience questions again. There was a question from Arthur in the audience about the conversion of the irreversible cessation of death to permanent. And just to clarify, that is not the UDDA that has been updated. That is a statement from the Institute of Medicine that has said, this is how we see it, and the country has essentially followed suit. But I think that question brings up a really important point, right? Which is that the definition of brain death is sort of an artificial solution to a problem that we had in the late 1960s. And one could argue that Jane laid out a really big problem, which is the gap between available organs and the need for organs. And perhaps is that a window for us to think about redefining death, or brain death? And if so, the process of the Institute of Medicine coming out and saying that permanent is acceptable, that was a decision from Institute of Medicine after consideration by different medical societies. But, in other words, that's something that's achievable, and it wasn't written into law. Is this the good time? Should we be talking about this? Should we be pressing this with our medical societies? Should we be trying to fast track this discussion?
I think the answer to that is definitely yes. And as you know, Catherine, we have brought this up. Dr. Dugdale and I brought this to the attention of the American College of Physicians. You have brought this up to the Society of Critical Care Medicine. I have brought this up to Live On New York, the Organ Procurement Organization in New York. I don't see why this cannot be dealt with quickly. I don't think it should take years. I think this is something that can be dealt with rather expeditiously by certain organizations which are involved in ethics and in organ procurement. And frankly, if there is a consensus among these organizations to change, and particularly it's the circulatory definition of death, I think that needs acting on, not so much the brain death definition, because even in England, it's the same as us. They just call it differently. I think that there could be expeditious action on that. We live in a democracy. And if there is a consensus that it's time because of the need to change and modify the circulatory definition of death, the way it was done from irreversible to permanent, then so be it. It will give ethical justification and an ethical imprimatur to carry on.
There are a bunch of questions in the chat about the procedure around ligation of the cerebral vessels. And I think that a lot of this has just a yuck factor associated with it. And perhaps that's what people are really responding to, this idea of the ligation of the cerebral vessels. And the question came up about the timing of the ligation. Jonathan, if you could just speak to that for a moment. In terms, or Jane, with the protocol, how long do you wait? Oh, wait, you're muted. You're muted.
I run the risk of being inaccurate, just because number one, I'm not a surgeon, and number one, we don't have an NRP program here, so I think probably best to sort of accept the yuck. Unfortunately, for donation after circulatory death in its current form, forget heart. In its current form, when there's cessation of breathing and there is immediate sternotomy and abdominal laparotomy, and then procurement of organ, there's a big yuck factor. These are amazing gifts that families can think of other people and knowing that this is what is required. And so, to me, ligation of head vessels is yucky. But so is rapid procurement of other vital organs. That is non-controversial.
I'm going to take a minute. I know I'm the moderator, but I'm going to just insert something here, which is that I think there is a yuck factor to it. But as a surgeon and an intensivist, the coordination of care for DCD donation is really actually quite beautiful. And so if you read the articles about DCD with NRP, the time from declaration of death to reperfusion of the heart, which is what's considered the warm ischemia time. And that's really a very important number to keep as low as possible to preserve the integrity of the heart. That's anywhere from 8 to 12 minutes. And so that's an incredible response from a team that's extremely well coordinated. I think, Jane, you had mentioned in the beginning that the donors are co-located. So in other words, the recipient is in the operating room next door to the donor. And just that level, so that you once you have the organ ready, you bring it right next door. That level of coordination and care and thought is actually quite beautiful. And for anybody who knows how these things work, things don't always go so smoothly, but these are incredibly smooth and well thought through processes. Jonathan, I think you wanted to say something.
It's sometimes new thoughts come as I listen, and they're not necessarily fully formed, but I'll just go ahead and say it. That from Dr. Prager talked a lot about the definitions of circulatory death and what are the challenges in thinking it through. And we also talked about the ex vivo approach, or the transmedic box. And that the difference here, when I'm thinking about my presentation, a lot of the human elements surrounding death and the idea of death as a process that can even continue after the moment of declaration, all those things would still be relevant to thinking about donation using the transmedic device or the ex vivo approach. And that's fine, as long as there's consent and people understand that this is going to be a very different process. And that is a trade-off in a sacrifice really the family is making for the benefit of others. But if I think about specifically the ligation, I think to answer those questions, I think we've made it, is that there's a 5-minute hands-off period from the timing from the declaration of death until the ligation of the head vessels. And the ligation of the head vessels is not, I don't think, directly to prevent the brain from sensing, but to prevent the brain from being reperfused, in which state then the patient could begin sensing. And so when we think about that act of ligating, we use that term, the yuck factor, which Jane also made the analogous statement to DCD for other organs, that after death is declared, that immediately there's sternotomy and harvesting of other organs. And so we can think of some similarities that in ex vivo approach, that heart is reperfused with circulation of the coronary vessels and the heart ejecting the perfusate. And so that's also a form of circulation. And so in some ways you can see a parallel to say that these are similar processes in which the ligation in DCD with ex vivo is that the ligation is that the heart is removed and circulation restored, versus in the NRP approach, the ligation is simply the head vessels and circulation is restored to a broader part of the body. So I can imagine some parallels there.
There are some questions from the audience about other countries that are doing this. So we had mentioned, I think, the UK, Australia, I think Belgium and the Netherlands perhaps are doing it. Is Canada doing DCD with NRP? There was a question specifically about Canada.
It's a great question. I don't know. Yeah, I don't know. I
haven't seen any data come out from Canada, the countries I mentioned before. But Ken, maybe you have mentioned before that that the countries that do use DCD with NRP are just different, sort of in their culture and in their values, and that may allow them to use DCD with NRP more comfortably. You want to talk about that just for a moment?
Well, I just think I think there are certain areas in Australia where euthanasia is legal under certain circumstances. I don't believe that's the case in the United Kingdom, though. In Belgium and Netherlands, yes, euthanasia is legal, and Canada, euthanasia is legal. So it may reflect a society's approach to end-of-life issues, declaration of death, and even euthanasia. People feel a bit more liberal about these things than countries that don't have it. I don't think it's a coincidence. I don't. Having said that, again, I just want to re-stress, I would not say that, I personally am unalterably opposed to it, but I think there should be a process by which something as grave as you decide when somebody is dead and whether you're killing somebody or not should have more than a few ethics committees or one or two ethics committees making a decision on behalf of the whole country, or just unilaterally. I think there should be, and I think logistically it's possible to have this considered by people who are advocates of organ donation, as I am, and to come up with a reasonable approach.
I think we might have time for one or two more questions from the audience. There's a question from, and I love that it's Dean Evan Hart, his name is, and he is asking if anyone has ever heard of an Alzheimer's patient being an organ donor, and whether that's an ethical, if there's any ethical ambiguity about a patient, I think Alzheimer's or otherwise dementia, suggesting not able to consent for themselves.
Oh, absolutely. I mean, first of all, if an Alzheimer patient became brain dead by our criteria, they could be an organ donor. If an Alzheimer patient had devastating neurologic damage and was likely to have a cardiac arrest within an hour of removal of life support, yes. We don't necessarily need families can consent for patients without even knowing what the patient would want. If you are in a registry, for example, in New York, hypothetically, the family can't even refuse to have you be an organ donor. But that's a touchy situation in terms of PR. But of course, an Alzheimer's patient could be, if they fulfilled the criteria of being a likely DCD candidate, they're on life support, the family wants to withdraw it, they would likely have a cardiac arrest within an hour, or if that Alzheimer's patient became brain dead.
I wanted to just address one thing about disparities in donors. It's a real shifting target. It's in California, probably the vast majority of donors are still motor vehicle accidents. So by definition, you either have to be in a car or own a car. In the state of New York, the vast majority of donors used to be gunshot wounds. Many people don't drive in the cities. And as it shifted to opiates, there's an opioid epidemic in urban centers, and there's also opioid epidemics in Appalachia and real rural centers too. So I think, so while there's very detailed data that's readily available to the public in UNOS on what is the demographic of donors, what is their race and ethnicity and sex and age and demographic, I don't know that we can totally predict, and it can just be run, who the donors are and how they change every 3 to 5 years or over decades and at different parts of the country. Just to put that out there.
I think that we are nearing the end of our time together. I want to thank everybody for just such an incredibly rich discussion. I think one of the things that I love about this topic is that we all agree that there's a problem and that it needs solving, and we need to put our heads together to come up with something that meets the ethical obligations that we have to our patients and to our donors. And so I want to thank Dr. Farr, Dr. Prager, and Dr. Hastie very much for their participation in this panel. And also to please thank the Columbia Center for Clinical Medical Ethics and the Columbia's Master of Bioethics program. Thank you to everybody here listening tonight for joining us. We will email a link to tonight's talk so you can watch it again. You can think some more. You can send it to your friends. I mean, this is something that we need to be thinking about as a larger community. And so thank you so much for joining us, and everybody have a wonderful evening.